Everyone, thank you so much for joining us. I'm so excited to be here with you all today. It's wonderful to see folks in person and online. As we kick off our first mental health forum this month, I just want to provide a little bit of context of why we're holding these discussions now. Why October? We're here today because October is the time of year to pay attention. Studies show that online search terms like depression, anxiety, fatigue surge in October. It's recognized as Depression Awareness Month. Mental Illness Awareness Week is the first week of October, and World Mental Health Day is October 10th. This is the time of year to pay attention to ourselves and to each other. As a community, we can support each other through this hard time, and we do that by talking about mental health. If we are collectively more aware of how we feel and know how and when to get support, I think we can make significant strides as a community. Before we kick off these discussions, I want to make you all aware of support available to you here at Rush, knowing that some of these conversation topics might be a little triggering for folks. The wellness pathways pictured here are an easy way for you and your colleagues to get the right help right away. Starting from bottom to top, you will see scaled responses based on how you may be feeling. Know that as a Rush employee or student, you can always access direct support from mental health professionals. Let's use these pathways, these forums, to acknowledge that it's okay to not be okay, to acknowledge that we can support each other in our time of need, and to acknowledge that you are not alone, that we are a community here. I'm delighted to introduce our moderator, Dr. David Ansel, seated here at the table to kick off these forums today. Thank you again for being here and taking time for your well-being.
Oh, there it is. Yeah, my wiring is not so good. Actually, this is a tremendously important subject, and we have a group of tremendous experts today at the table here, much more expert than me. I know what I'm feeling. They actually know how to help people with their feelings, and that's a good thing. So I wanted us to introductions. To my left, Eve Escalante. She's a social worker and manager of program innovation with social work and community health at Rush University Medical Center. And she's a tremendously intuitive human being, and really is someone I've gotten to know over the years as being, if I had a problem, I'm calling Eve. She's just tremendous. Callie McKinney, who is an APRN and a psychiatric liaison nurse at Rumsey, one of the tremendous services that we provide to our staff and our patients, supporting patients and staff through the inpatient medical surgical units. People get admitted to with a medical problem, but there's a lot of psychological and wellness issues as well. And she's a clinical nurse specialist, board certified in psychiatric mental health nursing, and works in the College of Nursing. She's really experienced in this work. And to her left, Dr. Gail Bosch, medical director at the Center for Clinical Wellness. And in the role, she has been a real advocate from the beginning about educational efforts and advocacy around mental health and well-being for medical students, medical staff, attending physician, and others. And she's a real, really a national resource to us. And then to her left, Dr. Cynthia Pierre, who's a licensed clinical psychologist with the Autism Assessment and Research Treatment Center at Rush, and she provides diagnostic evaluations and individual group family therapy to individuals with autism. But as a psychologist and a human being, really aware also of the impact of the external environment on how we feel. And I think brings that sort of personal experience and professional experience to this, as do the other colleagues at the table. And if we could just start and don't feel like you need to disclose if you're uncomfortable, how many of you, raise your hand, during the last 20 months felt a little bit blah because of everything that was going on, either in the medical center, in our families, in the world? Raise your hand. Okay, it's almost all of us. And I think, for me, who's kind of thick-skulled about this, I became aware in the pandemic that the isolation itself was causing problems that I felt. And a lot of times I just felt like I needed to get out of the house, I needed to do something. But I wanted to maybe turn to our panelists, maybe starting with Eve, and talk about like what's social isolation and what's the difference between loneliness and social isolation? What are the common symptoms and why did this matter? And maybe then our other panelists can jump in and talk about even the spread between flourishing and real mental health problems and how we identify and cope with those. But Eve, do you want to take the first?
Sure. Can y'all hear me? Okay. Thank you for the introductions, Dr. Ansel. And it's just a privilege to be with everyone here and definitely in person as well. So thanks for showing up. So I think, oftentimes and more lately throughout the pandemic, we hear a lot about isolation and loneliness, and it can be helpful to distinguish the two terms or concepts. So when we think of isolation, we're thinking of more of something measurable, an objective deficits in social contacts. When we think loneliness, we think more of the feeling of social isolation. And that, I'm bringing a social work lens to this conversation. So you may have somebody that objectively is not isolated. They have a lot of people around them, but those supports may be low quality or poor quality or actually sources of stress instead of nurturing and sustenance. And so it is possible to have a lot of people around you and still feel lonely. But we are thinking more about isolation in terms of how to measure this, how to screen for it. Even within the medical center, we've now added that to our next social determinants of health screener, looking at how many social contacts do you have per week, and then a referral to a social worker to dive into that a bit more for people who have limited contacts. And I think, to your second question about why does it matter, I think it's always mattered. I think through the pandemic, what happened is people of, privilege and power have been a little bit more impacted by isolation and loneliness than typical. And I think that that's, the silver lining, that it's getting more attention, but people have been isolated and lonely for a long time. This isn't a new concept. And I'm hoping that now that there's more attention, put towards this, we can find some sustainable ways to mitigate it. But it's always been there. Yeah. Anybody else want to add to that? Off to see if you can turn yours on, or maybe we can have them both on.
I think it's on now. Yeah, I'm so glad to hear that isolation is part of our social determinants of health. Isolation kills. And I think that isolation is an indicator of how I'm social work lens, substance use lens. So I think when our patients are isolated, they're that more vulnerable to starting substance use or progressing in substance use. And I think I was doing a little bit of reading, and isolation is a stronger predictor than cholesterol numbers or lifespan. Isolation kills, basically. Yeah.
Yeah, and I think one of the roles that we have as mental health providers is providing education to families and individuals about what different mental health, presentations look like. And I think that one of the things that's really important to keep in mind is that social isolation looks differently for different individuals, or that the symptoms, quote unquote, look differently. So the most, I would say, stereotypical or, I think common, so to speak, presentation is just depressed mood or low mood, feeling down, feeling withdrawn. But I do think that somatic symptoms, right? So increased stomach aches and headaches I think that irritability is a huge component of social isolation, especially for kids. And irritability and aggression behavior problems coming up during this pandemic, are things that I've noticed quite a bit in the patient population I worked with. And so it's important to see these as not isolated to that child or that individual, but as part of this constellation of symptoms that we might see.
And maybe just ask Callie, if you, on your observations and your work, both for staff and patients, what have been your observation about the impact of the social isolation during the pandemic on how people are not only feeling but acting?
Yeah, so that's been a real interesting period of time. Because I think it's pretty safe to say that no patient being admitted to a major medical center as an inpatient is going to be at psychological or emotional, and certainly not physiologic baseline. So they're already altered when they come in. So one of the reasons we even have psychiatric nurse liaisons and case managers and other folks is to help mitigate some of the emotional and psychological burden of serious illness. Then when we've added, so we've always had this happening. So it's acted out in various kinds of behaviors: anger, irritability, frustration. Often those come out in loud verbal outbursts. And unfortunately, it's whoever happens to come into the room. So for my nursing colleagues who spend most of the day in and out of the rooms, a lot of that stuff falls on them. They're kind of showering in it, and it's hard not to take it personally. And it gets hard to take a breath and try to find out what's the unmet need that's triggering this sort of aberrant behavior. And then it goes up from there, name calling, racial slurs, gender-based kinds of comments. People are operating with a lot of fear generally. So then we have the pandemic, and it has just really ramped these responses up by quite a bit. Many of our communities of color, there's always been an understandable amount of concern about trust. Are people working in my best interest really? And that, in my colleagues, in my estimation, has really increased some during this pandemic. In fact, we've been through a reckoning with a lot of injustices of many different types, but certainly racial disparities and injustices. And so people sound angry when they're worried and frightened. And as clinicians, the clinicians have all been burdened, right? Initially, in the first few months of COVID, everyone was terrified. What if I contract this virus and don't even know it and bring it home to my family, my baby, my parents who are elderly? And, we used to joke, it was kind of a black humor, but people would talk about all the rituals they go through in their garage or in their backyard, getting undressed before they even come in the house to take showers. And they couldn't see their family. They couldn't see people, or even when they could, they felt like they couldn't. They felt like they couldn't because the burden was too high. So the emotional quotient has just been magnified. What I think we're starting to see now, the fear for most clinicians isn't what's predominant. People are vigilant. We're vaccinated. We kind of know the drill. That said, though, there's an exhaustion now. There's a big exhaustion and a disillusionment about so many things we thought were in place and working, and turns out maybe not so much. And so it's just been really hard on everyone. I know this sounds extremely simplistic, and I'm not always able to follow it myself, but I've come up with a little mantra in my head when I meet with clinicians and patients and families who are just not, they're just to the right or left of center in the whole interaction. is, like my mantra is assume good intentions and assume that people are doing the best they can. Even if it looks kind of crazy to you, you can always step back, take a breath, say, whoa, just a minute. I'm going to be back in 2 minutes. I just want to recollect myself. Let's start over. So there's been a big uptick in the emotional responses of the staff and our patients and families who were not even allowed to be here for the longest time. That was crazy, right? That was really hard. And now they are, but it's limited. And so it's still a really difficult time for everyone.
Yes. Yeah, thank you for your comment. I'm going to ask maybe a little bit of a complicated question, so the answers will be complicated. And it has to do with intersectionality. I think, Callie, when you were speaking, it really made me think, and Dr. Pierre, when you were speaking as well, about how different individuals might manifest this differently, based on age, based on circumstances, and based on history. So a recent study came out in the past year that said 1 out of every 3 Black and Latino patients report that they've experienced discrimination in healthcare. They perceive they did in the past year. Very high proportion if you think about customer service, from any frame of things. So, and I was reflecting on that, as you said, that what you've seen as people come in and the mistrust. How do we navigate first that understanding? I like assume no, one thing is assume positive intent, but how do we as caregivers navigate that while we also are navigating our own heightened sense of isolation and maybe not at center, but a little bit to the left or a little bit to the right, as you mentioned. And we can get into diagnostics discussion about it, but maybe just to ask, maybe with Dr. Pierre, you start, and just hear from how do we navigate the space that we're in at this time in our history and given the pandemic?
That is a very complex question. I think that one of the things that we've grappled with, especially last summer, is that yes, we're in a pandemic, but some of these issues around racism are not going to wait. These issues are not going to wait. And I think that as providers, obviously, I think hopefully we can get to how we can engage in self-care and how this is something that we need to be mindful of in terms of our own jar of marbles and where we're at in that sense. But what I've learned and what I've had, the conversations that I've had with colleagues in the past year is that attending to these notions of mistrust or distrust, I think tends to fall to the wayside in favor of just getting the job done and getting it right. Like, okay, the clinical service is this, and we're going to get it done. And sometimes these considerations fall by the wayside when we are tapped out or when we are burned out. And I just don't, I think that we need to come up with ways collaboratively within our own clinics, the work that we do, to not let that happen, because that's how these types of divides continue, right? Is in the context of these types of crisis situations. And we can't, just let that slide just because, we have to, perform this clinical service and that's it. So continuing to be intentional about providing equitable care, continuing to be intentional about providing forums and opportunities to listen to patient concerns, incorporate patient needs in the work that we're doing, I think is essential.
Anyone else want to comment on that? I just wanted maybe a reflection of checking in. If this is true, how do we check in? If it's true of our patients, it's true of our staff, right? if it's true with our patients, true with our staff, if it's true with them, it's true with us. How, from a safety perspective, understanding that this is going on in our environment and it's affected a lot of people's sense of well-being and health, how do we make sure in the course of our days, we're checking in with each other around the isolation people might be feeling, either because of the pandemic, either because of the news that we've just heard, all of the conflict. How do we actually navigate this in both personally and professionally in our workspace? Like, what are the tools we should be using?
Thank you. I think that what comes to mind when I was hearing Dr. Pierce speak a little bit more about this, and initially your question, Dr. Ansel, is really beginning with self-awareness. And I think there's some inherent training for some of us in that self-awareness, and for other disciplines, it's not so much there, and really critical to rediscover that. I think one of the biggest challenges within our setting is that there isn't time created for that. And so if you're creating space for self-awareness or reflection, you're not getting the job done, like you mentioned, or sort of wasting time because it's not something we can check off of our to-do list. But it always manifests itself in our work, whether that's through quality outcomes or our own burnout, or however it's going to show up. So we've, within the social work and community health department, have had the privilege of having a consultant come in for about 7 years every month to run a case consultation for really challenging cases. But then also the second hour is our vicarious trauma processing session, in which we bring to light some of the small victories, big or small, some of the wins that we've experienced within our personal lives or work lives. But then we really also get to the really painful parts, the cases that represent a lot of feelings of hopelessness or helplessness, or things where the only thing that really is making a difference in the intervention is our relationship with the client, because nothing else is getting better. And that's been so helpful for our team to have that space carved out. And it's been so helpful for leadership to endorse that as an important part of our month. And I've had the privilege in the last year of sort of expanding some of that work along with Sally Lemke and Dr. Lowell and Lorena Ornelas as well, looking at different service lines too that are interested in having me come as a consultant for the vicarious trauma sessions. And that's been a culture shift for these departments, because again, it's not something that there's inherently space created for. Oftentimes folks show up and are not totally socialized to the idea of, what do I bring here? How do I open up? Or is it okay to say, I'm a caregiver at work, I'm also a caregiver at home, and what does that mean for me? And it's just been really eye-opening for me to have these sessions with folks. So if anyone's interested, reach out to me over email. I'd love to expand that across the institution and do more of it. But I think, again, if it's not something that we do tend to on our own and through our relationships, it's going to manifest. And I think part of that is getting over this idea that, I think is just such a social construct too, that we are individuals and we should not be interdependent. And that's something that is just so harmful in so many ways. The idea that we should just always be able to figure it out and pick ourselves up by our bootstraps and try harder. And I always think of the Nike logo, just do it. And you hear, why isn't this patient just doing it? Why can't they figure it out? And there's so many things I can't just do or figure out. And so I think it's really important to shift that culture as much as we can, even if it's with just 2 colleagues, our own department, our own service line, that it's okay to ask for help. It's actually important to ask for help. And, that change is going to be probably way past my death, but at least we slowly are getting to the point where we're valuing relationships, and it's not a sign of weakness to tell people where we're at and what we need.
Comment on that. It sounds like what you're saying, Eve, is you set up a process that allows the individuals in your department to check in. So it's one thing to speak up, and a lot of people say, well, speak up, but people don't feel comfortable. But it sounds like you've created a safe space within your department for people to have these conversations. They're dealing with difficult patients. First half's a case conference where you're talking about the difficult patients, but it sounds like the second half is is about us. And Gail, what are your thoughts on that?
It is about us. And I think our university now has really had a culture change with the Center for Clinical Wellness. I'm just going to plug it for a minute, but I mean, that's how we started this session. And I think more and more now, when we see people who aren't doing okay, you know, it like in real time, it's fine for us to say, I think you need some help and I'm going to help you get it. And we've made it super easy now. We have a pager, we have the 2323 pager. You can just pick it up and the center helps you figure out what you can do in real time. And we have, you know, various levels of acuity. We can get you some help on the spot, and you know, you can also get an appointment really quickly. And I think we now have a process which we never used to, right? And so I think we're destigmatizing. It's fine not to be okay, and oftentimes we're not. And we have services right here, which that's fairly new.
Thank you. Other comments? Callie, I know we have SOS, and I don't know how often we use that, but could you talk about that process? And I want to dive a little bit deeper into this idea of social isolation and for our staff, if we could. But talk about SOS and what you have when things happen on the floors.
Certainly. So we do have a process. Its acronym is SOS. It means support our staff. And any of the staff, it's been primarily used by nursing staff, but it is not limited to nursing staff. Wherein if an event occurs, either a patient-centered clinical event or a staff-related event, you can ask for that SOS. Managers can help get them set up. And Kim Sangster, our social worker turned clergy and bereavement specialist here at Rush, helps coordinate and manage those. Myself and Deb Mallers, the other psychiatric liaison nurse, we typically are part of those. And we use a structured format, which is really pretty simple. Kind of I feel, I think, I want, to give everybody a chance to hear in the room without dissecting the person's feelings, how people are feeling. They can write them down. We put them all up. Everybody can see the range of feeling in the room, which is really pretty useful. So you don't feel alone. It's not just you. And you might be surprised by some of your colleagues' feelings in a way that's useful. And then I think about the situation, what's been happening, and then how would we like it to go? What would we like to see going forward that might be helpful to all of us? And that can be things the people in the room are going to do with one another. It can be suggestions that the managers can help put into place. And that's been really useful. And, you know, a twofer on that, a number of months ago, I guess it was during the summer when we had a lot of the Black Lives Matter marches, and there was an episode or two of looting in the South Loop. And we had an SOS, not for that purpose, but for another purpose. And in the process of it, what came out were a couple of the Black nurses in the room were able to reveal that one of the big stressors in all of this for them is that none of their white peers asked them, how are they doing? And they lived in those neighborhoods and were having to go, you know, much further to go to a grocery store. Now everything was boarded up. It was very painful. And it was painful for their colleagues too, because their colleagues hadn't even thought about asking and felt horrible that they didn't. And so there was an opportunity that wasn't the reason we were called into that SOS, but there was an opportunity to begin to address, how do we know what's going on with one another? And how do we signal that in a way that can be supportive and helpful? So those kinds of opportunities, we still do them, and we do a fair amount of them. Although I have to say, I think in the last month or two, there haven't been quite as many for whatever reason. And maybe it's a staffing issue on the inpatient side. Things are pretty fast paced right now, and it's hard for people to feel like they can pull away. But yeah, we've been doing those, and those are helpful.
Yes. Any other comments on that? 'Cause I want to go maybe a little bit deeper into this sort of the idea of we all feel, there's been a universal experience during the pandemic of isolation. And then I think Dr. Pierre mentions, well, we all manifested in different ways. But there's, also a range of human feelings that are all come down. Some get to the point where they're illness. So you have either an addiction of some sort or another, could be food. How many people gain the COVID-19? Raise your hands, right? I mean, so there's food as the most common, smoking, use of other kinds of drugs. There's depression, there's anxiety, common denominators. But then there's this idea of languishing. In other words, you get up in the morning and you just don't feel like you've got to get up and go. The opposite of languishing is flourishing. And sometimes I think it starts with not checking in with each other. So this idea of sort of Black Lives Matter protests are going on. People are experiencing lots of emotion around it, particularly because it was as if some of us just discovered it for the first time. And, yes, this has been going on for like 500 years. But the not checking in when you're feeling isolated can feel almost as if you're not being acknowledged, that your experience, back to the patient ones, like just as our patients acknowledging, how do we move? How do we, and I know the wellness services are obviously an outlet for that, but how do we create the day-to-day around this? What are the kinds of things we should be doing with each other to check in with each other, to allow those safe spaces in perhaps maybe a more systematic way at Rush? I would really like to hear your comments. Dr. Pierre, do you want to, I'm putting you on the spot. You don't have a microphone either, so.
Thank you. Okay. Well, I think to dive a little bit deeper into the comment I had made earlier about the different presentations, I think this applies to both, our respective patient populations as well as ourselves as professionals, is what that in between looks like, really. And so I feel that in my personal life, as well as, working with families and patients, that there's some folks who are doing okay. Like they're doing okay in the sense that there's no clear functional impairment. There's no clear decline in day to day, and they're actually doing okay, or they don't, they might even say, I don't mind. I'm an introvert, it doesn't bother me that much that we're not, going out and partying and stuff like that. This is fine. This is actually within my wheelhouse. And so I think it can be really easy to just say, okay, well, that's great, and to just write maybe that group of folks off as they're doing well. And I think it's really important, both professionally and personally, to really dive into that a little bit more. Just because we are in a bit of a new status quo in terms of ways that we can maybe not engage with one another socially, because we have a really good reason not to. And so I think it's really important to assess some of the rationale or the function behind maybe making those decisions not to do things that, maybe we used to do or that we used to enjoy, and to make sure that they're not primarily driven by fear, right? And so again, we're not in the business really of challenging, well, I'm going to stay home to stay safe. Like, well, that's great, social distancing, great. But I do think that maybe probing a little bit more, I think, is really essential with one another about what it is that we're doing to stay healthy and to stay connected, even after this initial 2020 period.
Mental health has always been a stigma. And yet, when I ask everyone, raise your hands, everyone raised their hands, right? How do we begin? First of all, how do different communities respond and different age groups respond to the social isolation? What are their experiences like, and how should we identify this? I like, Callie, when you talked about anger, or a reinterpretation of anger is being hurt in fear has been an example of it. But how should we, with our patients, how do different sort of age groups and social groups, how does this sort of manifest itself? And how do you begin to have the conversation to destigmatize the idea that we all need mental wellness is part and part of our life experience? I'm just wondering if we could get you guys to respond to that.
I think one of the easiest ways, in my own experience, I defer to other clinicians as well, certainly. But to make a general statement, for example, as a psychiatric liaison nurse, when I'm called by staff to check in on a patient, I don't walk in and identify myself as a psychiatric nurse because that's got too much baggage, right? And then immediately that could put people on the defensive thinking, oh my God, somebody called you on me, right? But I say, yeah, I'm a support nurse and I'm here because being in the hospital is really hard and being here with a serious illness is even harder for everyone. And I'm just wondering in what ways in particular might it be hard for you? And I'm only asking you that to see if maybe there are some things we can do to make it a little less difficult. And people will just start talking for a long period of time. You don't have to do much else, but sit back and take in, what they're saying. And then of course, try to go see what you can do about those things they've identified. And sometimes they're real easy, sometimes they're more complex. But as simple as this sounds, what I'm feeling more relieved about these days is, as professional people, if you've worked in other places, there seems to be this idea that everybody has to be cheerful all the time. And they have to be smiling and they have to be on top of their game. And this is great and life is good. And it is all those things, but not always every minute. And this organization's branding is all about excellence. And that's a great thing. I think we are and aspire to be. And the thing of it is, so that doesn't mean you always have to say you're fine when you're not. And I'm kind of gratified that as I go through my day now, as I see people, if I say, and I mean it, like, how are you doing? I haven't seen you. And they go, hanging in. I go, yeah, I do know, because I'm just feeling like I'm kind of hanging in. And if there's time to talk about that more, fine. But I think it's just opening a door for people not to always say they're fine and they're great when they're not. And you may not have a whole time to unload all of that in the moment. You're doing something else. But it gives you a sense of other people are in this with you. And maybe perhaps you can find somebody to just have lunch with and talk about some things. And even find out how are they getting through that. Other people have some great ideas that, you may not have thought about yourself. So those are two things that come to mind.
Anyone else want to? Oh, Eve.
What came to mind is sort of two things when you asked that question, Dr. Ansel. The first is our social determinants of health screener and how we've trying to implement that across the institution. And, I think what's really helped as a social worker explain my role to folks is that, what's happening in the room today, right? With your medication, with your diabetes, with your cholesterol, with your cancer, is really a big part of the picture. But my role as a social worker is to think about everything that happens once you leave this room, and anything that happens outside of the room really is my scope. And that's been a way that I've found, really successfully allows me to introduce my role and how I can help folks. So I think that's one way we can destigmatize it is, you're here today for XYZ. At Rush, however, we really see you as a person, a whole person, and we see you as a person living within your community, your family, your neighborhood. And so these are standardized things we talk to about everyone when they come in. And that might be depression, that might be social isolation, it may be, violence, discrimination, all of those kinds of things. So I think creating space, but that's very challenging too. We have to think of workflows and sustainability because there's so much on folks' plates. And what we've often heard from folks is, we can't ask these questions if we don't have resources. And what the data shows us is that patients, even being asked, report that they feel better about their care and improved outcomes because maybe they don't have difficulty buying food this month, or they're not experiencing domestic violence this month or isolation this month. But now I know when I come to see my doctor, Dr. Ansel, I can tell him that because this is a place where I can share that. And that's a very unique thing that Rush has done. And I think something we should all be so proud of, but have to, continue to reinforce this. And I think the other thing too is that, again, social isolation is so new and sort of an important word right now, but it's so important to think those populations that this is their baseline. They've been, living in isolation for years or for decades. So it's so important not to just look at the squeaky wheels, right? And not that it would be negative in any way to bring that to light, but who are the folks that we can't reach? Who are the folks that are not calling us? We've seen this through our vaccination efforts. Okay, well, we're pushing this through MyChart. Well, what if you don't have MyChart? What if you don't have a smartphone? So it's so important for us to think about our innovative programming and is that accessible to people with cognitive decline? Is it accessible to people with hearing difficulties? Is it accessible to someone living in a neighborhood plagued by violence and they can't take a bus to the medical center? So I think we really have to think about this not as a new concept, but who have those people been, who are they? They've been living in the shadows for all this time, and how do we tailor our interventions towards them as well?
I want to open it up for questions in just a sec, but maybe just a couple of just final questions. And it gets to what you mentioned. There are people who are experiencing social isolation before the pandemic. And I'm thinking of adults, I'm thinking about families with children with disabilities. And you just maybe we could ask Dr. Pierre and maybe to start with the family one, and then maybe Eve with adults and folks with disabilities, like what are their special needs and how we need to be attending to them.
Absolutely. So I think that there's ample research to suggest that I think this is specific to, I'll say specific to autism. Parents report higher levels of stress in parenting and supporting, their children with autism more so than many other medical conditions. And so there is a very, I think to your point, Dr. Ansel, pointed element of social isolation that goes into it, right? If we think about just the amount of effort and support it goes into parenting these children or, advocating for them, it can be very isolating because maybe there's just not a sense of, community or connection with other parents in the same way that maybe, typically developing child's parent might have. And so I have seen, again, this is pre-pandemic, we don't have a lot to offer in terms of providing families with those informal supports, like, parent support groups, being able to have play groups and things like that. And so the fear, again, warranted or otherwise about COVID has really shut a lot of these opportunities down. And then, right, we're limited to those virtual options, which, to Eve's point, really might make the groups accessing those supports really even slimmer. And so I think that it's just something that as we come back online, so to speak, that we are making a deliberate effort to provide those in-person, face-to-face opportunities. How are you doing? How are you doing, not just as a parent, but as a human being? So that, that they can provide that optimal care for their families, but themselves too.
And maybe even Lou, of you answering, I'm sure it's very similar to isolated older adults. We can maybe take some questions from the group here.
I have a Hi, this is a college student and their program has went totally online. They were introvert, they are an introvert. So they've stated that exact statement. Well, this has been fine for me so far because they don't mind being away and not forced into high social situations. But now they are experiencing, they feel they don't have a true support group that you feel in a class setting, even though you are virtual with your class, but your classmates may be all over the country. So they don't have the meeting options there, that sort of thing. So what they did take the step to get counseling through the school on how to just address becoming a little bit more social, because they noticed this was truly missing and they didn't have the support of their family and friends there because they're out of state. So are there other methods, like they've decided they joined workout club? So they kind of join, and they're really enjoying that. They've kind of met a few people, but not really engaging long-term types of situations. So maybe you have some ideas on how to address these, not just college students, but even elementary children I've seen in our church are experiencing a lot of this. So
Anyone want to take that?
I think, we just have to be so person-centered with this. So something that may work for one person may not work for another. So I think one of the things that we've always tried to reinforce now that we're working on an age-friendly health system as well is what matters to people. And that can be a question we ask anyone of any age or condition. And so maybe what matters to someone is, connecting virtually. For me, that doesn't feel, I don't like that. But for someone else, it may really work. Maybe it means connecting back to their religious organization or faith-based program. For someone else, it might mean coming into the office. So I think it's just so important to think about, what brings you meaning and purpose, because I think meaning and purpose are really connected with the whole idea of loneliness and isolation. And based on that, I think everybody's, solutions are going to look very different, but that's why it's important we create some time and space for those conversations.
Yeah, I mean, and I think what we know is if we're not aware of, especially the younger age group, sort of building those muscles, they'll turn to things that aren't helpful. We're all aware of the Facebook stuff that's going on now. But especially for the developing brain, we're always seeking. We're seeking to grow and to know, and that's where the isolation has been particularly detrimental, because kids have turned to Facebook or overusing marijuana or substances, looking for that satisfaction, for that satiation. They're looking for something, right? And it's just not as easy in isolation to find that connection. So being aware that not especially younger group, but everyone is connecting. And I think you were talking about it earlier. Sometimes it's just easier not to connect these days. So even if it's virtual, connecting with a group of people on Zoom or in some sort of meaningful way, it's tough.
And just to stick with it, I think, think about like the first day of school, like amplified by 3, right? Like it's going to be awkward and it's going to be uncomfortable. And I think a lot of folks are like, oh, this isn't for me. And so I just think it's important to, I think, collectively let things thaw out and see if they're, that kind of collective awkwardness and discomfort that I think a lot of folks are feeling can allow for more meaningful social connection within the groups that the person you're referring to is trying out.
Someone asked on the chat, can a person be socially isolated while still working full-time or being a full-time student?
Yes. Yes. Like, I think one of the things that I strongly dislike about Zoom is that we were talking about this. You can only have one conversation at a time. You cannot have those side conversations. There's just no way. And so if you're not involved in whatever it is that the main person's talking about, you're just, I don't know, you're active, you're passive, your bystander.
And I think there's another piece to this that everybody is probably recognized, but I don't think we think about it a lot. You know, communication isn't just like words, and it's not just facial expressions, even though half of our face has been cut off now. There was a comedian recently that said, wow, she went to a store and realized there was a baby smiling at her, and she smiled back at the baby, and she goes, I have no idea if that baby knew I was smiling unless she's looking at my crinkly eyes, you know, kind of thing. But it's also energy. Unless you're in proximity of other people, you don't always feel what's going on. It is another way that we take in our environment and kind of get cues about what's happening in the room. Is there excitement? Is there anger? Are people kind of down? Or is there like a certain confusion? Is it buzzing in here? Some people are more sensitive to that than others, but everybody's impacted by it, whether they realize it or not. And so sometimes we just have to make decisions. Yeah, it's a hassle to make all these plans and make sure people are vaccinated and wear a mask and do all this. I bemoan the lack of spontaneity, but it's worth it. It's worth it to be with other people, even if everything isn't perfect or the way we would, like it to be. And I think we have to be patient with our discomfort and the discomfort of others. Nothing has been decided yet. It feels like, remember that game of pickup sticks? You got to be old, I guess, to remember. You need to throw these pickup sticks and then you try to pick them up without moving the rest and having them all falling apart. And that's kind of how things feel right now. There's a lot of ambiguity that's not comfortable for most of the way our brains work. And so I think we have to take a breath more frequently, and remind ourselves to be kind to ourselves and each other, because this has been and still is a very challenging time.
Quickly,
Yeah.
yes.
Terrific panel. Thank you. I have a very loud voice. And it just maybe, we had an event where we had ministers come here to get vaccines. And I walked in the room, I'm generally very upbeat and energetic, but I cried at that moment because here we were all in a room together, socially distanced, masked. The idea of being in each other's presence is a huge, huge deal. And I just wanted to acknowledge this. And I'm not a crier, but I cried because it was realized, I didn't realize what I was missing. And sometimes the absence of something, it's only when it's present you realize the feeling. The best thing I think we can do is check in with each other and say, in this transition, in uncertain times, with our family, with our friends, I just want to check in with you, how you doing, but also be able to share how you're doing and say, you know what, this has been kind of hard for me. Because I do think without that human dialogue, and for those folks who are isolated, these are like just simple things we have to do. Of course, we have these resources here for people and say, do you know that you go talk to someone? We all need it. And so I just wanted to end on their note. And there's no shame in this, even though sometimes it feels shameful to be feeling this way and needing help. The more we can support each other, the more we can sort of use our resources that we've put together. We used to never have them, and look how much we need them. So I just wanted to end on that note and thank everybody for coming. I would like to get up.
I was just gonna stop.